Good morning. Thank you for being here. Very excited to welcome you to our session today. My name is Jay Rajda. By way of background, I'm an academic internal medicine physician and a clinical informaticist, and I work at Amazon Web Services in the global healthcare group. My role is to help empower global government health agencies to adopt technology solutions to meet their business needs. Amazon Web Services is Amazon's technology arm. It's Amazon's cloud services business. And our aim is to empower global organizations with cutting-edge technology. So most people in this room are no strangers to the public health challenges that we face today. The cost of healthcare is at unprecedented levels, and it's rising at a rapid clip. Access to healthcare services remains a challenge. It remains inequitable, and this leads to inequitable and poor outcomes. There's also all of this is exacerbated by skilled workforce shortages. In our discussion today, we will discuss how government health agencies around the world are leveraging technology to address some of these challenges. So beyond just setting policies and standards, what types of technology investments these agencies are making, these governments are making around the world, what are they actually building? So in our work with government health agencies around the world, we are witnessing investments in 5 distinct categories of solutions and infrastructure. The first is the foundational capabilities. These are the building blocks for digital health transformation. The nuts, bolts, and pipes, right? And in the recent years, we've seen increasing adoption of technology for recording healthcare information, so for documentation of healthcare encounters and things of that nature. But this hasn't really translated to better outcomes because information that's captured in these encounters does not make it to the point of care where it's needed for clinical decision making. So the first category of investments tackles that issue. This includes capabilities like citizen identity management, which forms this fundamental foundational capability to identify citizens, which forms the basis by which their health information, their healthcare records can be associated with them. And the second type of foundational capability is national health data exchange. So these are the pipes that can carry information from one point in the health system to another point where it's required for decision making. So we've got you'll hear in the discussion today about how these foundational capabilities have been developed. There is RNDS, which is the National Data Exchange Platform in Brazil. You'd hear about that. You'll hear about NHS Spine, NHS Login from in the United Kingdom. You'll hear about these foundational capabilities in India with ABDM. This second category of solutions is digital health front doors. The challenge, another challenge that agencies across the world are trying to address is availability of health-related information to citizens. So digital health front doors are single entry points where citizens can access from that entry point information about their own health as well as information about healthcare services, both digital as well as traditional. And you'll hear from our panelists about how this is being done very successfully in Singapore as well as Australia. And so these are great investments. They lead to great citizen engagement and better outcomes as well. So you'll hear more about that. Now, when you have the ability to collect information, collect data about healthcare, and then you have the ability to digitally engage citizens, then you can invest in programs that can promote the health of citizens. You can survey the health of the population and then invest in specific programs that can promote the health of citizens. So you'll hear about some of these programs. There is a national vaccination program in India. There is a lung cancer screening program in the United Kingdom that's led by the NHS that they identify high-risk patients for getting lung cancer, and then they screen them in the community with mobile CT scans and use advanced AI to assist with the diagnostic process. And the fourth category then addresses the challenge of affordability. And this is a critical issue. There are segments of the population that can't afford healthcare, and that leads to inequitable outcomes, poor outcomes for that subsegment. So the fourth category of investments is in this bucket, solutions that address this. Government-sponsored healthcare. There are great examples of this. In the United States, the CMS, Center for Medicare and Medicaid Services, has an online health insurance marketplace that allows citizens to purchase health insurance online in an open marketplace based on their eligibility, based on demographics, based on income. And in India, they have a health insurance program that covers 500 million citizens, unprecedented scale, the world's largest health insurance program, and you'll hear about that as well. And the fifth category is research. So this is nations have a great opportunity to leverage technology to further science, to make advanced therapeutics available to patients that need them. But that requires, in addition to having national data banks that collect genomic and clinical data of individuals, you need advanced computing power to conduct that analysis. So there are great examples of that as well, with the UK Biobank investing in developing a national scale biobank, and then trusted research environments to enable global researchers to access that data and conduct analysis. Genomics England in the United Kingdom as well, and then the CIFAS initiative in Israel. So if you'd like to learn more about these initiatives, we are releasing a white paper today. You can download it using the QR code on the screen. That's got all of these examples, the ones we'll talk about and more. So I'd encourage you to download that. Now, the common thread underlying these very diverse initiatives is the technology foundations on which they're built. These are the critical considerations for agencies as they build these capabilities are the key aspects of technology, the foundational technology that underruns all of these capabilities. So the foremost amongst that is security. This is the top priority of the agencies that we work with. It's critical to maintain public trust. So this is a key advantage of building in the cloud, because because of scale economies, cloud service providers can invest significantly in security-related capabilities, and then the agencies that build on the cloud can then access the same infrastructure that's used by militaries and global banks across the world. It also provides easy access to advanced security features like access control, identity management, access control, encryption, and then also compliance to a plethora of international security standards. The second key consideration is reliability and resilience. So this is absolutely critical in healthcare, and this is a top priority for agencies. See, as a physician, I need my systems to come on when I'm seeing a patient. It can literally be the difference between life and death. It's a matter of life and death. So a very important consideration, and this is also a key advantage of the cloud because of the way its systems are architected in the cloud, with multiple geographic regions with significant redundancy between the regions that allow for a fault tolerance and protect from local outages and disasters. And I'll take the next two together. Agility and elasticity. Agility is the ability to build solutions faster, and elasticity and scalability is the ability to scale up and scale down your capabilities based on needs. So these are critical considerations, again, for healthcare agencies, because it allows them to respond more effectively to the needs of the population. So think about building a national vaccination campaign during the pandemic, or building a national scale virtual care platform based on emerging needs of the population during the pandemic. So having the ability to build fast is critical. And this is, again, a key capability in the cloud, because in the cloud you can deploy resources at large scales, thousands of servers and compute capabilities and storage with a click of a button. And again, it allows you to build solutions faster as well because of what we call managed services. These are managed packets of code that can quickly be put together to build services faster. And finally, a key consideration is costs. This becomes an important consideration when building new programs involves upfront investment in infrastructure. So when that happens, there could be budgetary limitations that limit agencies to make those investments when they're needed. And the advantage of being in the cloud is that you pay for these resources as you use them. It's like a utility, like electricity. You pay for only what you use. So that's you can trade your capital expenses for your upfront capital investment expenses for variable expenses. So again, these are the key advantages. Without further ado, I'm going to invite. We've got a great set of panelists today. We're going to talk about all of these examples. First up, our speakers will discuss the development of the foundational capabilities that we discussed, including citizen identity management and national scale data exchange. So we have amongst us Paula Xavier dos Santos from the Secretariat of Information and Digital Health from the Ministry of Health in Brazil. And she will discuss the development of Brazil's national scale health data exchange network and related applications. Hello?
Hi. No. Okay, thank you. Okay. Good morning, everyone. I'm Paula Xavier. I'm the director of the Department of Information and Informatics of the Unified Health System. This department is under the Secretariat of Information and Digital Health in the Ministry of Health in Brazil. It's a pleasure to be here with you today. And unfortunately, our secretary, Estela Dat, could not attend the event, so I will be speaking on her behalf. Well, I would like to begin by giving you an overview of the unified health system in Brazil. And it's important to say that no country in the world with more than 100 million inhabitants offers a unified health system completely free of charge. Brazil has now a population of more than 200 million, and 70%, that means 150 million, depends exclusively on the services offered by the unified health system. When we come to the SUS digital, it's also important to say that it's the first time that the Brazilian government has a national program and a policy too, with research to promote the digital health ecosystems. This program, named SUS Digital, it's very relevant to say that the program is really connected with how the SUS is structured and organized. So it's an aim to the program to be as comprehensive and resolvability of healthcare in the primary care, middle, and complex care. And the program is based on the pillars of the unified health system in Brazil, that is continuity of care, equity, and quality. Okay. The SUS digital program asks the two states and municipalities to fill two important tools. The first one is a situational diagnosis of the care network and the National Digital Health Maturity Index. Both of these tools are really important to understand how digital health is going in Brazil and support the states and municipalities to do their action plans. And positive aspects that 100% of the states and the municipalities addiction by the join the SUS digital program. You know that how large is Brazil, so that means that more than 5,000 municipalities is part of this program. In the part of the Ministry of Health, we are developing some projects, structural projects in digital health, like electronic medical records, integration of information systems, patient access to their health data, unified medical record accessible during care, integrated telehealth strategy, and one of the most important policies that I want to share with you today, it's about the National Health Data Network. So the National Health Data Network, RNDS, is the national interoperability platform for data exchange in healthcare. RNDS is foundational project for the Secretary of Information and Digital Health and for the SUS digital program. It's an initiative by the federal government aimed to promoting the digital transformation of healthcare in Brazil. So we went to a process in Brazil that where before the information systems were very fragmented, like different information systems for exams, results, services, vaccines, and now we have an integrated process that really integrate one to another, and from different points of care. So don't mind if a patient go to a hospital or a laboratory, and all this information is integrated in this platform. These slides show you how much data we already have in RNDS. Currently, we have more than 2 billion registers. 1 billion of these registers are about the administrated immunobiologics, not just the routine vaccines, but the campaign vaccines and COVID-19 vaccines too. And Brazil is participating in a very important project in global context that is in the International Patient Summary. Well, all this information that we receive at this interoperability platform, RNDS, is disseminated through 2 platforms that we name SUS digital platforms. The first, named Meu SUS Digital, is the platform dedicated for the citizens, and the SUS Digital Professional for the health professionals. In the Meu SUS Digital, we can bring the citizens closer to their health information. So a lot of, not just information, but a lot of services too, like you can do an appointment, you can see your own historical clinical data, and other very important services. One of the most recently features that we implemented in this app is the self-declaration of race color and self-declaration of social name. This is very important for Brazil, that the most of the population are black and brown. So, like I said before, we don't have an integrated information, so it's very difficult to use this evidence for formulate public policies. And in the SUS digital professional, it's a platform dedicated the health professional can access all the historical clinical data of the patient just in the context of care. So he can see different informations from the different levels of care, health sectors, medical records, and locations. So in this last slide, sums up a bit of what RNDS is about. From RNDS, we can have a comprehensive look through out of the patient journey and shows how really integrated the health services could be. So, for example, we have a patient that in 2014, he was in Manaus, a state from the north of the Brazil, and he received a diagnosis of hypertension in a basic health unit. In 2019, the same patient was traveling with his family, and he makes some imaging exams with a specialized doctor. And 2022, he could see his prescriptions, medications prescriptions at the app Meu SUS Digital. And in 2024, he followed up with an obstetrician in the private healthcare network. So this is so important to have this integrate information for the citizens, for the professional, and for the government too. That's what I want to present to you. Thank you so much for your attention.
Thank you so much, Paula. That was great. Great stories about developing the foundational infrastructure for the pipes, as well as citizen engagement with digital health front doors. Much appreciated. Thank you. Up next, we have Mr. John Quinn. Mr. Quinn is the Chief Information Officer for the National Health Service in the United Kingdom. Mr. Quinn will discuss how the NHS has built foundational elements in its digital health infrastructure, as well as how they are reimagining the patient experience.
Good morning, everyone. Just press this, do I? Okay, back one. Right, my name is John Quinn, and the NHS is really interesting hearing that and speaking with colleagues last night about how common we all are, but how different we are too. And some of the common things that Jay brought out, I think will become clear. So in the problem statement that we're trying to address is that we have a national organisation, which I represent, that delivers mainly commodified, repeatable, common platforms of capability that are basically, a large amount of them are technology-based, but it includes things like our strategy, our architecture, our profession, the meaning of why we are in this profession together. So I think that's our role, almost like the servant of the system, but where the value is created is at the front line. And the reason for popping this up while I talk is that it's quite a busy slide, so hopefully they'll get simpler later. So our response is something that we've called One Digital. It's a strategy that's underway at the moment, and it breaks down into 4 areas. The top 3 being the things that we think we should do, the what's, and the bottom one being the how. So I'm just going to touch on those now, and then I'll focus on the citizen piece, which is the thing that I think is probably where the value is created. So starting from the bottom, one digital way. The thing is about technologists. I have 200 CIOs that work in the system running trusts and hospitals, is they are independent of mind. They like to do the things their own way. This is to be rewarded. I like that they do these things. But somehow there's a risk that they can go their separate ways and do things differently. And that leads to cost, it leads to difference, it leads to different patient journeys. So we need to address that. So one of the things we're trying to do is to have one digital team, a profession of 40,000 digital professionals with a common standard they're working to. That's backed up by one digital blueprint, and the blueprint is a common way of talking about what we do. So if you get to a CIO who's talking about patient flow, some will show you their systems. But if you can compare that in the same way with another CIO who does it a different way, you're able to spot where those differences lie and exchange where the best practice might be. And that professional piece is really important to combine with them together. And then one digital process, which is the controls and the red lines. Thou shalt never build a data center again might be one of them, for example. And finally, the commercial framework, the leveraging of spend across our National Health Service so we can get best value and make ourselves a good customer for people like Jay and others who wish to support us. Building up from the bottom, that message around sustainable infrastructure and hardware, we have a generational challenge in front of us. We have servers under desks. They are open to cyber attack. Jay, that piece around delivering that link to better outcomes. In fact, some of the things that we need to do is to make sure that systems don't fail and cause patient harm as a result. Cyber attacks, because we have vulnerable legacy infrastructure, is a real problem. And so the argument around that is not just cost, but it's actually about releasing time and energy of people who should be focusing on our customers. So there's a whole range of work there. And we were talking last night about how you articulate this to ministers who want to trust that this all works. You have to articulate it in ways that says it takes 10 minutes for someone to log in the mornings. Those 10 minutes multiplied, that frustration that occurs. If you can make infrastructure, whether it's the kit they use, right up to how they interact, if you can get that right, you are releasing time for care, and that's a real benefit for our users. The bit around data is interesting too, because in those systems, you can design them to interact. That's where interoperability and standards come to play. But as part of our approach is how can we additionally abstract that data? How do we recognize local difference where people can have their data, but build them in with common tool sets, with the ability to bring that data together? Because actually, being able to provide a national view of data is really critical, and something we certainly learned during the pandemic. And the final bit is the focus on patients. And for us, we have an NHS app, back to that interface. But that's as useful because it's a way of driving user-centered design and streamlining business processes as a result. So what have we achieved this far? I won't read the slide out, but hopefully it looks quite pretty, so you can observe it for a while. I'll pull out a couple of areas. Booking vaccines is important, streamlining logging is important. But if you start to think about how we take this disparate system and allow people like me to access my GP record, but even more importantly, to be able to access my mum and her GP record, order her prescriptions, repeat that performance. When she's lost those prescriptions, order them as an emergency. All of those things are life-changing, not just for the patient, not just for their carer, but also for the taking cost out of GP time and others. So I think that's a really important aspect of what we've just done so far. And you can see this is starting to become a real tip up. This has been steady, but actually in the past 18 months or so, we've seen a real uptick in use. For us, 3 out of 4 people, 38 million people in the UK, which pales into insignificance to India and Brazil, I have to say, and others. But that's quite a lot of people who now, for our view, have healthcare in their pocket. And that's pretty clear for us. If we can design around those users, you can streamline off the back of it. But you have to come at it 2 ways. From the bottom up, fix the infrastructure. From the top down, design around users. I'll jump on. So one of the missions of the new government coming in is where they've described we need to move from analog to digital. That sounds great. We all get that. What does that actually mean? beyond a statement? Well, it means some quite important things. And for us, over the next 5 years associated with our spending review, we want to change this interaction of the citizen to make their interactions with us in the healthcare sector digital by default. I'm just going to touch on a few more. Jay, I did overslide this one, so prepare for a whirlwind of colour. There are a few things I'm going to give you a sneaky peek at. This is what we are trying to achieve. You can read these slides, but I'll focus on the ones where there's a problem statement. 30% of calls into Coventry Hospital are from people asking if their referral has been received. Now, that kind of admin is huge for people who have to respond to that. We have to take that cost out. I'll let you read the rest. Our view is that if we can get people managing their data through the NHS app, that's critical. And one of the areas that is spotted particularly is on things like notification. So we have a system, a service called Notify, and it's not universally used. People still send paper. They still send various different messages. The costs associated with that are huge. If you can take out that cost, automate it, you can improve the life of patients, you can improve the quality of the data, and ultimately you can improve better outcomes. Sickness to prevention. I mean, this is big. Cost in acutes and in medical settings is huge. How do we focus on treating people where they are happiest? 36% of people are not aware of the services that are available to them. It's quite a low uptake for us. We have to start addressing these issues. And when you start flipping back to what benefits they can achieve from that, they're quite significant. Health records. Now, we've done a pretty good job digitising our health records and in some instances, even changing processes rather than just digitising paper processes, which is always a challenge. The key for us is that while we are trying to address people now, there are some really interested, digitally savvy people coming along now for whom actually being able to access all their information in one place is critical. Again, it's about designing for the user so that they are immune to the complex paddling under the water that takes place of those systems that are costly and don't interoperate. And of course, diagnostics and treatment to help people back to work. It's quite a big economic advantage with having people working. And if you look at musculoskeletal issues, this is like growing in the UK. Now, there is a way, I think, of addressing some of those issues, and online help and support, connecting people who might otherwise had not accessed care is really important. And one of the things that we've discovered, some of the biggest uptake in the use of the NHS app is in areas that are deprived, where people are not used to going to see the doctor. And so we can jump through that process and get that uptake for the poorer citizens in the UK. We can help them have better health outcomes, but also reduce the burden on GPs themselves. And then finally, of course, keeping people out of hospital would be great, not just for them, but for the costs and the rest of it. So picking up medication, 33 repeat prescriptions. I mean, there's just so many life journeys that are open to transformation through digital. I think that's it. Let me just flip forward. That's it. That is it. So in terms of what I think the point I want to make is that actually, if you focus on the citizen for driving out change, and that's using modern digital techniques, having a product mentality, changing how you fund for us block funding, trusting people to deliver outcomes, and if you address the underpinning infrastructure and data, actually between the two of them, you can transform a health service. And it's really critical we do, not because of the outcomes, but actually the affordability point that Jay mentioned earlier.
Thank you, John. I think the NHS is a terrific example of combining foundational capabilities with digital health front doors to drive better outcomes by designing programs that promote citizen health. That's great. And thou shalt not build a data center. That's a quote we're going to go back with. Thank you. Up next, we have Ms. Shri Kiran Gopal Vaska, the Joint Secretary for the Ministry of Health in India and additional CEO for India's National Health Authority. Mr. Vaska will describe how India has built not only the technology stack for the foundational capabilities, but also describe how they've built the world's largest health assurance program for more than 500 million citizens of India.
Thanks. Have you been standing for too long? Why don't we skip, swap places? Thank you, Jay. Good morning, everyone. So I've been tasked with talking about two of these schemes under the Ayushman Bharat umbrella. Is a Sanskrit word that means a healthy and long life. So the whole objective of Ayushman is to have these four foundational pillars. Two of them talk about the infrastructure at the primary health care level, and the other one at the tertiary health care level, improving the infrastructure. The other two are the ones that Jay has mentioned. One is the insurance scheme, the other is the digital health intervention. So the National Health Authority, which is a attached office of the Ministry of Health and Family Welfare, is tasked with running these two missions. Now, just to talk about these two pillars, the challenges in the healthcare system in India that we identify mostly are about accessibility, affordability, and quality. And the ABPMJ, the first one, the logos are somewhat similar, so it might get a little confusing. The first one is about providing a 5 lakh rupee health cover per family per year, which democratizes access to services across the country for the most underprivileged, economically underprivileged sections of the country. The other one is actually about building protocols and building that foundational network or the foundational layer on which other digital services, health services can work in an interoperable manner. So to talk about the insurance scheme, the PMJY first, why we needed it. This is a very, very simple graph where we just try to show the poorest 40%, the hospitalization rate versus the chronic morbidity. As you can, and the richest 40%. Whereas the richest 40% are able to access these services much better or more than what their comorbidity rates are. The poorest, there is a huge gap. And it is estimated that 55 million Indians slip back to poverty every year due to catastrophic out-of-pocket expenditure. I mean, imagine a family earning maybe 10,000 rupees a month and the four families surviving on it. And suddenly, there is some health expenditure to be done of, let's say, 50,000. They cannot afford it. You have to take a loan or borrow it from someone. And there starts the spiraling down. Then the non-communicable diseases burden has been continuously increasing in the country as in the rest of the world. And this is affecting everyone equally, irrespective of economic status. And it is estimated that 48.2% out-of-pocket expenditures are made on healthcare in India. And so as a result, the scheme was started. What these features are about. One, like I mentioned, a health cover of 500,000 rupees per year per family. No cap on the family size. No waiting time. No inclusions. Completely paperless, and this is where the technology part comes in. And it's a cashless scheme. There's no concept of reimbursement. You go, get yourself verified, get yourself treated, you go home. Now the hospital submits their claims online, which are processed online, and the payment is made online. And it covers secondary and tertiary care of 27 different specialities. And there are 1,949 different packages. Now, this whole concept of package is again unique to the PMJY, where we cover everything from the first 3 days initial diagnostics to the post-discharge 15 days of medicines, and also even other medicines if some cases where more usage of medicines are required. So this is what basically the scheme is all about. And to look at the statistics, every PMJY beneficiary gets a card which looks like the size of a credit card, a plastic card, mainly as a measure of empowerment. I mean, just imagining a poor person going to a big hospital, a private hospital, and trying to prove his identity and saying that he or she is a beneficiary of a particular scheme versus simply showing a card. We all know how empowering it is. So out of a total coverage of around 650 million, already 355 million actually have a card. And close to 30,000 hospitals are operating this scheme. So far, 79 million treatments have been provided under the scheme. I mean, with an expenditure of 13 billion. This 13 billion is again a misleading figure, simply because when we purchase at this scale, we do what we call strategic purchasing. What is available in the market at X, actually we buy it at maybe half of that. So the actual out-of-pocket expenditure saved for individuals is almost twice of this. So $26 billion worth of out-of-pocket expenditure saved for the poorest 40% population of India. That's the kind of impact it has. And on the gender equity side, as you can see, it's at par, it's almost equal. And also a unique feature. I mean, India is huge, 36 states and union territories, each having their own set of hospitals, each having their beneficiaries, and a lot of migration that happens. So irrespective of which state you belong to, you can access health services in any other state. And the entire settlement is done from the state that you come from. Here is where I just stop a little bit and talk about the tech part of it. So on an average, close to 75,000 admissions happen every day. And there are a lot of set of activities that are undertaken to avoid fraud, which is very much possible when you're trying to implement a scheme of this scale. So every time a patient goes to a hospital saying that, look, I'm a beneficiary, we do an Aadhaar biometric authentication. Aadhaar, as you know, is India's unique identity, a digital biometric identity. The person has to give either a fingerprint or a face scan or an iris scan, just to ensure that it is the beneficiary who is actually going and getting treated. Then there is a setup, and the entire the hospital, there are close to 1.5 million people who have access to the system. It could be at the hospital level, someone who is registering the patient. It is at the field level, a field level worker trying to create a card, a beneficiary card. It could be a processing agency trying to process an insurance claim. It could be a state government finally approving and paying that claim. So 15 million people are accessing the system on a daily basis, and this is running day in and day out. And this is possible only because it is running on a technology platform. We could not have imagined doing this scale of work if it was not automated. We had a scheme called RSBY, again an acronym, but the whole idea is like the scale of RSBY compared to the PMJY is, I think, an order of magnitude of 1,000 times bigger. PMJY is 1,000 times bigger compared to RSBY. All of this is because of the fact that online or a cashless or a completely paperless approach that was taken, and it was decided from day one. And in fact, PMJY, the scheme itself, was launched across the country in a record period of just 4 months. So this is the kind of way in which the technology was leveraged, and that's how the services are currently being developed. And in terms of even the creation of cards, the creation of PVC cards, at the peak, we created 19 million cards in a single day. So, I mean, the scalability, the use of the architecture at the back end has been designed in a way that you scale as required, because sometimes there are different drives that happen. So the whole idea is when you use technology in the right manner, then you are able to scale it up and deliver these kind of services. So in terms of impact, like I just mentioned, we cover 650 million Indians. A new beneficiary 220 new beneficiaries are added to the system every minute. 38 hospitals are added into the network every minute. 38 hospital admissions are happening every minute. 12 new hospitals join the network every minute. And 496 grievances are resolved every day. And this is the kind of scale that the PMJY is operating on. So technology for providing quality access, and those 30,000 hospitals that I'm talking about, half of them are private hospitals. Half of them, those private hospitals are also come from the best hospital chains in the country. So you can be the poorest of the poor, but if you need some surgery that needs to be taken, you can actually go to a best hospital that is available in the country. So that's all about PMJY. Coming to the digitization part. So there has been a mention of building these foundational technologies. How do you build systems that are able to help leapfrog a country from its nascent stage of creating paper trials, paper records, paper reports into a digital system? And this is where the Ayushman Bharat Digital Mission, earlier known as the National Digital Health Mission, comes into picture. The idea here is unlike in the PMJY, where we actually have built an application and we run the application. Here, we said no. We will actually build the foundational architecture, design the protocols, and then let both the government and the private sectors build on top of it. So this is how the India health stack looks like. You read it from the bottoms up, where there are certain cross-domain foundational digital public infrastructure that the country has already created, including Aadhaar, the unified payment system, things like DigiLocker, where this is a national locker system for every individual to keep their digital records, the e-sign, and then most importantly, the consent artifact. The idea is when data moves from place A to place B, it has to happen with the express and clear consent of the individual. So this is where a consent artifact, a digital artifact built as a digital public good by the Ministry of Electronics and Technology in India is actually being leveraged. On top of that, we have built fundamental registries, that is IDs, health IDs for citizens, IDs for professionals. It could be a doctor, a nurse, a paramedic, which are all digitally verifiable. And then digitally verifiable registry of facilities, a hospital, a clinic, a diagnostic center, a hospital of Indian traditional system of medicine. So all these facilities are put in a digital registry. And when these digital entities participate in the ecosystem, they are all verified entities, therefore trust becomes a very important part of how this network works. On top of that are these three verticals that you see. These are what we call those gateways. The first one, the unified health interface, is actually the digital front door for services. So under this, we just do three things. One, enable interoperability of services. A citizen should be able to use an application of his or her choice. A provider should be able to use an application of their choice. In spite of that, each one should be able to discover the other, book a service, avail it, and pay for it. It could be a physical appointment, it could be a digital consultation, it could be a lab test, it could be searching for a blood bank. So this is what is about the unified health interface. So basically, it's a gateway with a set of protocols where you connect from one end as a citizen, the provider connects from another end. How many of us are here approximately? We must be what, 150, right? If 150 of us had to handshake with every other person, how many handshakes would it be? Sigma n minus 1, right? That's not possible in a country like India, where there are 2,000 different types of HMIS systems. There are 800,000 different types of hospitals, ranging from a single doctor clinic to a super specialty hospital. So this is where we said, no, let there be only 150 handshakes, but let them all shake with one particular entity so that everybody is connected with each other. So there's a network in between, there's a gateway in between, everybody connects to it. Through that, the whole transformation happens, the movement happens. So the health information exchange is basically about that, where everybody connects to the system. There are set protocols based on FHIR standards, and we have created those standards of data exchange so that data can be exchanged from one hospital in New Delhi automatically with another hospital in Bangalore with the consent of the individual. And the last one, the claims exchange, is also about how do you simplify the payments process for health insurance. Because it is also very clear that insurance is a very, very important part on how healthcare is delivered, and without insurance, we won't be able to improve the quality of services as we see. So in order to do this, we created what we call the National Health Claims Exchange, which again is a gateway with a set of protocols. So today, if there is a hospital and 10 different patients come with 10 different insurance policies, they don't have to deal with 10 different portals. You use one portal, the claim in a particular standardized format goes to the claims exchange, it's resolved there, and the information moves to the concerned insurance or the payer. And similarly, the response comes back. So this way, interoperability of claims is also ensured. This is where the government building stops. This is where we stop. Everything on top is where we say is built both by the government and the private sector. Again, government is only building the reference applications. We show an application, we build an application to show how it works and how it is to be used. And today, more than 240 different kinds of applications of different kinds, personal health record applications, HMI solutions, lab solutions, insurance companies' payment systems are all linked with it, all built by the private sector. So this is the approach that India has taken in building this whole government stack or the health stack, where we said we will build the foundational architecture, we will build the protocols, we will build the gateway, we will build the data exchange formats, and then leave it for the private sector to use this innovation to develop it further. And again, technology is an integral part of how we do this. So what has happened so far? Now that individual health ID, 674 million Indians now have a digitally verifiable health ID that he or she can use, or to which health records can be linked, so that the longitudinal history of a particular citizen can be created. More than 480,000 professionals are now here, and they are providing these services. And more than 340,000 facilities. We still have a long way to go. There's a lot of other hospitals to bring in. But to give you in a nutshell, the health information exchange, the unified health interface, and the claims exchange are the three gateways that are enabling interoperability of services, interoperability of health data, and interoperability of health claims. So this is India's approach to how this is done by using technology to build national scale applications for providing better quality healthcare. So ecosystem participation is what we are trying to bring in, and I think this is the next step of adding more and more players and finally making sure that this objective is met. Thank you so much.
Thank you, Karan. Incredible scale, incredible impact, incredible India. Very inspiring. Up next, we have our speakers are going to talk about the development of digital health front doors for citizen access to healthcare services and support. We have with us Ms. Bettina McMahon, Chief Executive Officer of Health Direct Australia. Health Direct Australia is the national virtual public health information service that's funded by the Australian government and forms the digital front door for citizens of Australia.
Thank you, Jay. Good morning, everyone. I'm going to provide a little context about Australia before explaining the virtual front door that we've set up. So Australia has a population of 27 million people. About 7 million of those live in rural and remote areas. Our system is funded through a combination of the states that fund our hospital system, the federal government, which funds primary care, and essentially a bunch of small businesses in general practice and pharmacy who deliver that primary care, and they're based in an activity-based funding model. Some of our challenges are maintaining continuity of care across a fragmented system, and also improving equity of access for some of the most vulnerable Australians, including Indigenous peoples. So Health Direct was set up as a national organisation where people could come when they don't know what to do or how to access care. So last year we had 84 million interactions with our community. 5 million of those were over the phone and the remainder digital. The digital interactions are largely people seeking triage through our app and website. Interesting to see the NHS, you said 30% with the app. We have about 3 digital interactions for every phone one, so we're sort of the other way around. People searching for health services, we have a National Health Services Directory with 150,000 services in it. And just doing basic web searches for symptoms and conditions, that's the vast majority, over 50 million of those. So I'm going to take you through how a consumer experiences the virtual front door that we've set up, and then I'm going to explain what that virtual front door is also doing for our health system. So the front door starts with a consumer triage where we ask a bunch of questions to a consumer. Now, 2 years ago, we implemented an AI clinical decision support system, which is what you're seeing here. Now, the reason we switched to AI was because our previous non-AI system couldn't deal with underlying conditions like asthma, diabetes, obesity, couldn't deal with risk factors around lifestyle and demographics, and it couldn't deal with multiple symptoms particularly well. Now, all of these things are increasingly important for accurate triage. So in this example, I've cut out a bunch of questions. Basically, the system continues to generate questions using a Bayesian probabilistic inference engine until it has confidence about it actually does a probable diagnosis. We don't display that, but what we use it for is determining what the outcome is for this patient. So in this example, they're recommended to see a doctor within a week. Now, if you phone us, there's actually an extra step in between these two pieces, which is after the CDSS comes up with a potential outcome, the nurse has the option to accept that outcome or to triage it up or down. Now, we operated our new CDSS on the phone line for 12 months before we made it available in the digital channel. And what we did during that 12 months was we monitored the quality of the outcomes, and we provided feedback to Informatica, who's our CDSS vendor, on the nurse changes. And so that feedback loop helped them to improve their foundation model. And then after 12 months, the number of up and down triages nurses were making had really reduced, and that's when we made it available in the digital channel. So in this example, see a doctor within a week. There's 2 more things I just briefly want to show you that Health Direct does. The first is providing self-care information, and the second is that service finder. So we've got thousands of articles of quality information about how patients can safely care for their conditions at home. Our popular articles are in more than 16 languages. Now, at the moment, those languages are manually translated by translators, which we're looking to change. If you're on the phone, the nurse explains this and they send you a text message with a link to this information. But if we also recommend that you access a health service, we make available that National Health Services Directory I mentioned with 150,000 services. So this one here, anyone who's been to Sydney might recognise this as a central business district. Here we list the relevant service, so a doctor, things like the opening hours, scope of practice, whether it's free or not, the languages they offer, etc. And the consumer can then choose from this list which provider they want to go to. I'm going to show you something here, the next available appointment. Now, we don't have a national booking system like the NHS off the spine, or like the Choose and Book system or others I've heard my colleagues talk about. Rather, I mentioned earlier the general practices, about 8,000 general practices in Australia and about 6,000 pharmacies. They purchase their own booking system from the commercial market, and there's about 20 different booking service providers there. So what we did was we built Fire APIs into each of those booking engines so that we can bring back available appointments in real time and have it in an aggregated view here for the consumer. And then if they click on that, we send them into the environment, into that general practice or vaccine clinic or whatever it is, and they make their booking from there. So in terms of consumer experience, the virtual front door helps us to inform a consumer about how to manage their symptoms and how to connect them with appropriate care that is suitable to their needs. But what does it do for the system? So what I didn't mention is we actually built a bunch of this infrastructure during COVID with COVID funding, and for consumers to understand whether they were eligible for vaccine. We had eligibility criteria in Australia to manage supply chain and then to make a booking. So we operated this from 2021, we built the infrastructure. And a little context in Australia, we have one of the highest rates of vaccination in the world. So 97% of Australians have had at least 1 dose of the vaccine, and 95% have had 2 or more doses. So Health Direct, we ran the eligibility checker and managed the bookings through this infrastructure. And between March and December 21, we serviced over 50 million sessions of Australians connecting. Our busiest day on the 22nd of September 2021 had almost 350,000 vaccines administered. Now, I thought this was pretty impressive until yesterday when I was talking to Kieran, and he tells me that on their busiest day, not 347,000, I think it was 25 million doses administered, which is the entire population of Australia. So I need to get this slide off here. Don't listen to me. But look, this is the sort of scale we're talking about to run a national health system that you need. For us, you're probably joining some of the dots. You know, we're fully cloud, have been since 2020. I can't see how you could possibly deliver this through on-prem infrastructure. It's just not an option for us. So cloud deals with the scale that we need, but it also deals with surges in demand. So the sort of business I'm in, we have massive surges up and down. Some of them are seasonal, some of them are daily. And so being able to deal with that surge in demand and then to release the capacity when we don't need it is really important. And cloud works well. I think, Jay, you described it as elasticity. So that's really important to us. And I'm going to share one other advantage of a virtual front door, how it helps the system, before sharing a few final observations on the critical success factors we've needed to have a national scale transformation. So the virtual front door is also a way to improve productivity of the health system as a whole, and it does this in 3 ways. So the first is providing right care first time, and ultimately this is the main business case for a virtual front door. The reason you do it is so you can you can direct patients to the pathway which is best for their symptoms and reduces low-value interactions in the health system. So this diagram shows the range of outcomes of triage that we can direct patients to. And I won't go through all of it, but you can see of all of the callers who said that they intended to attend an ED, because we asked them what were you going to do, we were able to divert 51% of those safely to lower acuity and lower cost care. So the better our triage becomes at being able to safely de-escalate care, the care setting, the better value we can achieve with the same health outcomes. The second way that you can improve productivity through this is through just better utilisation of capacity. So when I showed you earlier that we could see real-time availability of general practice bookings, we can see the same with vaccine clinics, with pharmacy. We haven't got it for hospitals yet, but we're working on that so that we can see the wait times for particular triage categories. That lets us see the latent capacity across the system in real time and connect patients to it. So rather than having to build more capacity, we can have better utilisation of that capacity across at a system level. And the third way it can improve productivity is by using our data to identify gaps in services. So we were able, after 6 months of using this new system, we were able to go to governments and say, look, we can see say Bathurst, a part of New South Wales, in this particular geography, on a weekend, our ED referrals increased 200%, and that's driven largely by 3 symptom factors. The first is breaks and fractures. People are out playing sport on the weekend and encountering more fractions. It could be conditions that require a physical examination and medication, such as a potential inner ear infection, and kids with gastro. Parents with kids with gastro is one of our biggest use cases. So we were able to say, look, in these places at these times, these are the symptoms driving demand for the ED. And what 2 of the states were able to do was stand up new services. So they've implemented what they call urgent care services. You can see this here, urgent care services. So that's basically a general practice which is open extended hours through to 10 p.m. at night and all weekend, co-located with diagnostics. So they've got radiology at a minimum there. And pharmacy. So we can send a heap of people there during those times to get a full diagnosis and treatment outside a hospital. And for the kids' gastro, 3 of the states now have opened virtual EDs where these children might need more intensive monitoring, but they can do that safely at home and they can do it virtually, which is great because the geography doesn't limit the availability of that service. So in the 2 states where we've done this, we've been able to halve the number of patients that we've referred to ED over the course of a 6-month period. So look, finally, Jay, I'll wrap up soon. Observations about critical success factors. Cloud-based tech, an absolute no-brainer. I've covered that already. Using AI, so where do we start with AI? Often that's the big question, where do you begin? And it's tempting because vendors will come to you and say, hey, we've got this fantastic thing, you can use it. For us, we actually started with our strategic priorities. So what's our unique value proposition? What do we need to do better? For us, that was triage to begin with. Our triage tool was becoming less fit for purpose with all the reasons I explained. Next, a big focus for governments is improving access to care, and so that's why we're looking at real-time translation on the phone line. So we're looking at having a consumer call and speak their own language and have that translated in real time to the nurse. So we've got manual translators, we've got people doing that at the moment. It's a really shitty consumer experience. So we're looking at language translation as well, and we're also working on RAG AI for self-care information. I showed you earlier our self-care page. We've got thousands of those pages. Look, they're beautifully written. Probably everyone in this room would be able to understand it and act on it. But what AI does quite well, and we've heard through other sessions, is we're really good on the empathy. It's really good on rewriting things in a way that consumers can understand and connect with. And ultimately, we're at war with misinformation. So we invest a lot in search engine optimization to get our content at the top. And a success measure has been the number of clicks we get. I want to move the success measure to how often people are taking our advice. And they're more likely to take the advice if we can rewrite it in a way that is more empathetic, more consumable, and at the correct educational level. And so we've been using Claude AI. We had a hackathon, which is AWS's tool that does this, but it constrains the model to our content. Anyway, if you want to talk to me about that later, happy to. Having strong relationships with tech partners, really important. I talked about Informatica. We do a lot of work with AWS. So we're all in the secure cloud environment and working with some of their partners to help with things like translation. Anchoring our thinking in the broader health system context, which is around productivity, how we're getting more bang for buck in health outcomes for the money available, and access, and sensitive to what the community expects. And then finally, the importance of earning trust and how quickly you can lose that. Having been, working in transformation across government for many years, I've got the scars of big reform projects and big IT projects where we've lost trust along the way. And so really that trumps everything. If you lose that trust in the policy objectives and what you're trying to achieve, none of the rest really matters. Thanks, Jay.
Thank you, Bettina. Thanks. It's great examples of how you can promote citizen health when you have an engaging digital health front door. Thank you. So up next, we have Professor Dr. Ki Yuan Niam, the Chief of the Academic Informatics Office for the National University Health System, or NUHS of Singapore. Dr. Niam will discuss the development of the My NUHS app, their digital health front door, how they've developed health promotion campaigns for folks with chronic conditions, as well as how they are using advanced AI technology to drive better outcomes for citizens and patients.
Thank you, Jay. So my talk will be a slightly different direction from the ones that I shared. Indeed, Singapore is, in comparative size, probably a tiny little state in India, right? So we are just slightly under 6 million population and 100% urban. So we don't have maybe some of the issues that we have with outreach and rural kind of healthcare provision. But it also forms a microcosm to experiment on new technologies and how we can push that technology to benefit our patients as well as our practitioners. Singapore has, just for background, we have a public-private kind of payment insurance system where more than 60%, everyone in the country is covered by a public insurance system, as well as the private insurance that citizens can pay by themselves. So this sets the stage for the kind of service provisions that we can provide in Singapore that's slightly different perhaps from in other countries because everyone is covered one way or the other. So that changes the way we structure the healthcare system and how we then want to advance a healthcare system that arguably is providing quite a high level of quality as well as access. So what we really want to do in the long term is to really flatten that cost curve, right? As our population grows and our population ages, we want to use technology to flatten that curve And it all starts with thinking about policy and long-term planning. And a lot of this was covered by the earlier speakers about how their countries look at policies and how you implement certain long-term plans to ensure that your healthcare provision can be steady over many decades. So one of the key differences between some of the things that you've heard this morning is that Singapore has been on a digital health journey for a good part of two and a half decades, right? So the very first electronic medical record systems came into production in 1998, right? So we have quite a lot of experience with electronic data. 100% of Singapore's healthcare system is on electronic and digital. Then the question is, how can we bring everything together? So we've had many iterations of health information exchanges. And so what is really coming to fore in the last 5 years is we're going to bring together everyone onto a singular electronic medical record platform, which currently we use EPIC as the EMR system. And this singular EMR system eliminates a lot of intermediary type of efficiencies. Like, for example, having separate exchanges, having multiple APIs that different systems have to call each other to get services. And many of these systems today are very, very mature. And on top of these systems, like many other countries, we build many of our services. For example, our digital front door, which is the NUHS app, the app that my cluster of organizations uses, that provides all of the services such as appointments, bookings, payments, chat services, requests for medical records. So I think from that point of view, that has been built in the last 5 years and is at this point fairly mature. We are not nearly at the scale of Australia or India that we have heard earlier, but certainly it provides most of the services that we have saw earlier, including things like vaccinations and tracking children through their child health. So we still have a gap to be filled with the private GPs that are still functioning in their own electronic medical record systems, but I think by the end of this year, we hope that we can bring all of the private practitioners onto the same platform. Now, moving forwards, I thought I'd show this rather complicated diagram about how we approach the adoption of AI and technology going forwards. So this diagram tells a story that's now spanned 7 years. So it starts from the bottom where we have built a platform to aggregate all sorts of healthcare data across the different silos of data that we've had in multiple platforms. And this gives us the ability then to work on large data sets, right? To undertake data analytics and run model building over large data sets. And this capability has opened up the possibility of building AI models at scale. So this is one of the things that we wanted to do very early on, that is to build AI models at scale. And being able to aggregate the data has given us that possibility. Now, the second part of this story was that we are able to put together the EMR system, but we can't use that data effectively on our AI models. So we built a second platform called Endeavour AI right in the middle. And this platform has given us the ability to now stream data from electronic medical record systems in real time. Now, this is transformational for us because it means that multiple systems now can be deployed for the purposes of patient care or clinical decision support to our doctors on the singular platform. And this is further enhanced in the last 3 years by connecting it to the healthcare commercial cloud, which is a secured, sovereign sort of in Singapore kind of version of the AWS commercial cloud. And this has given us the access to large language models, which is so fundamental for everything that we do. Because if you look at this next diagram, we've built a language model called Russell GPT. And this is not just simply a large language model. It is a model that is capable of routing different services to a central large language model platform using the AWS systems as a backbone. So this, as you can see, there are a couple of diagrams, boxes here that I will not go into great detail to explain, but simply put, whether you are providing a chatbot service to a patient or to the doctors, or you're providing English level tasks like summarization and letter writing, this is all capable today in a secured environment. So unlike many of the language model deployments today where data is sent outside of the country to other sites, this is an in-country language model that we are using to enable us to run all of the services. Now, on the right, you can see a number of boxes, and this is what we call the RAG, or earlier it was mentioned that we can use RAG for specific guidelines. Now, these guidelines are now being curated by doctors to enable us to give precise and yet accurate information to our doctors for clinical decision support. And then on the bottom left-hand corner, you see some red boxes there. So that's the integration with our earlier platforms, which is the Endeavour AI platform. And this gives us the ability to stream that data and automate many of the large language model services that we are running. We've done a nice little experiment with our doctors on integrating large language models in healthcare. And this was published in Lancet Regional Health in the Western Pacific. And this has given us real insight into implementation of technology, which is, one would have thought that providing a large language model to doctors is a good thing. But we found that in reality, adopting that technology is a lot harder because doctors want efficiency, right? But it doesn't mean that you give someone an efficient tool, they would make use of it fully. So in this particular case, we found that the doctors who use those models are on average 40% faster in a written task than a doctor who doesn't. So this is quite interesting, and however, there are some limitations as we found. The machines weren't able to pick out on certain nuances in care, and this is something that we're working very hard to address on our models. We also use models to run summarization, write letters, do ambient transcriptions. Earlier, we heard from other panelists about the technology being invisible, being available without needing to run any particular task. So this is a good example of how we want to do this, being able to run this technology in an almost invisible way. So one of the cool things that we can do today is something aspirationally was attempted many years ago by IBM Watson Health, which is to use large language models for tumor board suggestions. So this particular tumor board focuses on breast cancer, so we are able to give correct treatment suggestions to our doctors in about 95 to 98% accuracy using standard guidelines. So, and it's not just giving the guidelines, and it's also able to give the evidence behind the guidelines in a very structured manner. So in summary, I would say that we want to adopt technology, especially in the cloud, to enable many of the things that we wish to deploy to improve the outcomes of our healthcare. And we also want to measure it, right? We talk a lot about technology, we talk a lot about implementation, but we talk less about measuring. So one of the ways we measure it is, you can measure it in very specific ways or in very global ways. So one of the global ways of measuring it is longevity. I think just a few days ago, there was a nice article in the BBC about how Singapore is now one of the blue zone countries, right? And this is a term coined by a Nat Geo journalist, Dan Buettner, where we are seeing a huge increase or almost a doubling the number of octogenarians in Singapore in the last 10 years. And these are all the results of carefully planned policies. It's not a situation where Singapore had a long tradition of high longevity. In fact, in the 70s, our life expectancy was 60 years old. Today, the life expectancy is 86 years old. And that became real in almost two decades. And the reason for that is a combination of policies, built environment and long-term planning that enabled us to do this kind of global or population scale kind of uplift and outcome. Yeah, thank you very much for your attention. Yeah.
Thank you, Dr. Niao, for sharing a glimpse into our future. Up next, we have Professor Dr. Alain Lebrique, Director of the Department of Digital Health and Innovation for the World Health Organization. Dr. Lebrique will discuss how nations that are earlier in their transformation journey can accelerate their transformation and how the WHO can help.
Fantastic. Thanks, Jay. And, let me actually start by asking everyone to close their eyes. Now, close your eyes. Imagine a beautiful blue lake, still water, and on that lake is John's earlier referred to duck, right? The beautiful white duck that you see on that lake. And that's what patients, providers want to see. They want that duck, that beautiful duck that's sitting there calmly, quietly, and giving them some happiness. But what's happening under the water is that duck is paddling furiously, keeping himself afloat. Those little webbed feet are working away in ways that we don't appreciate above the water, but without which that beautiful white duck would just go floating down into the water like a rock, right? So I think that's a great image that you've planted in my head that I've been seeing now for the last 20 minutes about the underappreciated plumbing or infrastructure that every single panelist today has driven home as a message. So it's really an honor to be here today to talk about digital health transformation. And I'm a WHO civil servant. And right now I have 5 of my 194 bosses on the stage, so no pressure on me to do well. But I want to recognize that countries like Brazil and India have really, through their recent G20 presidencies, shifted the needle on this conversation. Where we've moved away from talking about playing with digital to investing in robust digital public infrastructure. And Australia, Singapore, the UK have really played important roles in showing how person-centered national systems can only be built on robust foundations that include good governance. And good governance is about solid policies, architecture, standards, and those are the things, that's the magic sauce that creates and enables trust. And I think it's something that we can't take too lightly. So what WHO is focusing on, and to echo John, is how do we build systems that not only improve outcomes, but release time for what matters, and that is patient care, both from the analog systems, the burdens and mountains of paper that people are working with, but also from dysfunctional digital systems that have been generated over the last 2 decades, not with person-centeredness in mind. So many of us were at the New York UN General Assembly a few weeks ago, where we saw the center stage that digital transformation enjoyed. And is it because digital and AI are the word of the day, or is it because we see that without these tools, we will not be able to accelerate our progress towards SDG and meet the lofty ambitions that we've set for ourselves? Only 17% of the SDGs are on track. Only 17. So that's a really long task ahead of us if we want to get there. And so at the General Assembly, I hope everyone here is familiar now with this new tool, which is the Global Digital Compact. And what this member state resolution document captures is how do we move forward responsibly with these technologies, digital health and AI, in a way that doesn't introduce or amplify the inequities that have failed so many of us through the health systems that countries around the world have today. So one of the things the compact brought forward, and I've highlighted the text here on Article 15, is that without investments in the solid foundations, the stuff that each panelist has talked about today, in the DPIs needed to promote person-centered experiences and interoperability, we will not be able to achieve the goals that we set for these digital transformations. So from 2011, WHO and ITU have worked together on advocating for planning and investing in national systems, beginning with these foundations. These are the canonical sort of 7 building blocks of robust digital transformation. And we've been talking till we were blue in the face, but it's exciting to see that these foundations are now being put into practice. And you can see the fruit of those investments now a decade, 2 decades later, in the amazing country case studies that you've heard from today. So just last week, we had governments and implementers gathered in Cairo to discuss digital transformation at the Global DPI Summit. Now, these were discussions across many sectors, and health was just one of these verticals. But what we were talking about is how do we create the DPI, the digital public infrastructure building blocks, so we stop reinventing wheels, right? It's important that we have foundational infrastructure, like Kiran pointed out, the Aadhaar national ID systems, the trust infrastructure that prevents the one-to-one relationships that occur between facilities, and create those things that don't have to be reinvented over and over. John, I think you said, "Thou shalt not rebuild." You know, what are the core building blocks that across government services, and for me specifically within health, save time, money, and improve interoperability? So there has been a recognition of this term DPI, and if there's one word you leave with today, that should be the three-letter acronym. That has crossed UN and development partners. And some of my colleagues are here on the stage, some of you are in the audience. But from the World Bank's leadership last year in launching the flagship report called Digital in Health, to USAID's recent position paper on this topic, there's a collective recognition that we should not continue to invest in piecemeal solutions, hoping to achieve digital transformation. Right? I'll let that sink in for a moment because that's a really important message. We can't talk about transformation on one hand and keep investing in digital experiments on the other without investing in those foundations. So today, WHO actually supports digital public infrastructure. And you know, like Singapore, I'm also embarrassed because India is a hard act to follow. But we're supporting 80 countries through this digital certification network that enhances people's ability to cross borders with their personal health records. And so these 80 countries today cover roughly, 78 countries. It should be corrected. Let me move it one more forward. There we go. 80 countries. It covers about 1.8 billion people on the planet. And so to Kiran's sigma n-1 formula, imagine if 80 countries had to create bilateral relationships with each other. Here, WHO provides that handshaking where we provide the public key infrastructure to verify the provenance of health data without touching or holding any patient data. But I think the first question that we need to ask as we leave this room and bring this session to a close is why make these investments? For the countries that are early in this journey, why drive this shift from small-scale, politically driven or donor-driven projects to national transformation? And so there are 7 strong, let me just plug through them right here. For us, there are 7 strong reasons that we think drives countries to adopt digital public infrastructure. From enabling individuals to have access to their personal health records, to supporting the accountability, as India and others have shown, of public funding and management of claims, to ensuring that health workers are paid on time. The digital public infrastructure is a key enabler of all these important drivers of better health. But what are we talking about when we talk about digital public infrastructure? Because we've gone right into the weeds, but I want to take a moment to bring us up a few 1,000 feet. Because this is the plumbing that's often unseen and unappreciated. But if you can figure out what this is on the diagram, I think most of you can, boy, do we know when it's not working or when it stops working as it should. As a father of teenage kids who often stop up the toilets, I can tell you I'm very much an appreciator of good plumbing. These are the roads and highways on which the vehicles of innovation run, and the infrastructure that few people want to think about and even fewer people want to pay for. But these are the digital commons that should be invested in once and used by everyone developing digital solutions as shared resources. This is the vaccine against wheel reinvention. So let's take an example very quickly of the personal health record. We've heard today many examples. In Jay's words, this is an example of the digital health front door that we heard from Bettina in the Australian example. But what is a personal health record? The record is comprised of multiple types of information about the user, where they got care, from whom they got care, what commodities they received, etc. Now, this record draws from a whole series of digital health public infrastructure, provider registries, patient registries, product catalogs, etc. But most importantly, they also benefit from foundational public infrastructure, such as digital identities or trust architectures. Now, this could be a topic we spend a lot more time on. Unfortunately, we're 2 minutes from the end of the session. So I hope that many of you will look at some of the work that's being done across the UN system. We just put out a call for applications for experts who want to help us develop digital public infrastructure reference architecture that helps the countries who are starting on the journey learn from the Brazils, the UKs, the Indias, the Singapores, and the Australias of the world, so that they can kickstart their journey in this process. And I'd like to invite everyone to also join us in a deeper dive in early December in Nairobi, where we'll be hosting the first Open Digital Health Summit, where we'll be talking about countries enabling about 100 governments working with their technology partners to build DPI-based digital transformation action plans. So it's really a privilege to be with you all today, and thank you, Jay and Amazon, for bringing us all together and having this excellent conversation.
Thank you so much. Much appreciated, Alan. Thank you. And thank you all for your impactful and inspiring work that touches millions of lives. It's very inspiring. And thank you for sharing your stories today. Unfortunately, we do not have time for Q&A, but we'll stay back and welcome the audience to come up with questions if you have any. I'll also leave the QR code to the ebook on the screen in case you want to download it. It's got all of these stories. Thank you.